Hello, today we'll be discussing emergency trauma surgery. Trauma is the leading cause of death among individuals between the age of 1 and 45 years, and it's the third leading cause of death in all age groups. You will see a lot of trauma in the hospital setting, and depending on your location, you could see quite a bit. What's real important for this chapter is your terminology review. I do want you to familiarize yourself with all of the terminology found at the beginning of this chapter. Make sure you know each term and its definition. In any true surgical emergency, more so than any other situation, teamwork is the key to a successful outcome for the patient. Although the ability to respond quickly to the demands of the surgery is important, accuracy is the most crucial component in a surgical emergency. I have to repeat that. Accuracy is the most important. Yes, we want to be fast. There's no question that we want to be fast, but fast and wrong doesn't work, and it will not lead to saving a patient. Getting it right the first time takes less time than a rushed mistake, and any mistake puts the patient at a risk. A part of this teamwork is clear communication. It's extremely important and is mandatory during an emergent situation. Our current trauma system in the U.S. Provides for a specific designation of the healthcare facilities. That means that each hospital has a specific designation stating whether they can handle certain levels of trauma. So these levels, this system that it's designated by is a numerical system and identified with level 1, 2, 3, 4, or 5. Level 1 hospitals have the greatest capacity to handle all types of trauma. These designations they're established by the Committee on Trauma of the American College of Surgeons, and also by individual state laws. The rating has to include factors such as the number of trauma specialists on hand, how many physicians are certified in trauma care. So all of these things play a part. How many beds are available? All these things play a part in that rating. The American College of Surgeons has a certification for physicians called the Advanced Trauma Life Support Course, ATLS, and we're going to refer to this ATLS throughout this chapter. The course focuses on ATLS treatment guidelines and protocols for trauma. Because remember that every decision in medicine is based on evidence based research. So this is no different with emergencies. This is studied, and certain protocols are put into place on how to handle individual traumas. The decision to perform emergency surgery is not taken lightly. A complex chain of physiological events occur during trauma cases. The events require deviation from medical and surgical algorithms or treatment pathways. So, what we're used to seeing is a certain algorithm. A patient comes in with a pain, a specific pain. That pain and the location of that pain leads to a certain algorithm or a treatment pathway that sends you through tests and diagnostic tests and surgeries and aftercare and so on and so forth. Those are very specific on how they are aligned. And the reason for this is so that you have specific treatment that people can trust when they go to each hospital, wherever hospital they're going to. So trauma requires deviation from that algorithm. It's a big deal. Understanding of very basic trauma physiology is necessary to appreciate these decisions that are made during trauma. Three physiological conditions are a primary focus of assessment and decision making in trauma patients. These conditions are often referred to as the lethal triangle or lethal triad. Patients who survive the first hour after an injury are at risk for these following conditions. So, if we have within that first car accident and our first responders can keep that person alive for an hour to bring them to the hospital, these are the things that are going to be our main concerns. We have hypothermia, which is the subnormal core temperature for an extended period of time. We have metabolic acidosis. This is a lower than normal blood pH. And also coagulopathy. This is a potentially lethal disorder where the normal blood clotting mechanism ceases to function. Hemorrhagic shock is the vascular failure caused by prolonged severe blood loss. So, this is the most common cause of mortality in trauma. During severe hemorrhage, a drop in blood pressure occurs, and the body's natural response is to constrict the blood vessels in the peripheral vascular system to preserve blood flow to the heart, kidneys, and brain. So, when this happens, this causes a deprivation of blood flow to the extremities and to the abdominal organs. The lack of blood causes the cells to take on interstitial fluid from the vascular system, and inflammatory chemicals are also released into the body. If not treated immediately, ultimately tissue death will occur from hemorrhagic shock. Compartment syndrome is tissue swelling within a closed area, such as you can see in this picture, in muscle bundles in the limbs. These bundles are surrounded by sheets of fascia and encased by superficial tissue. So you can see here we have muscle. This is in the leg here. We have a fascia that holds all that muscle in. Okay. The fluid buildup is from damage to that tissue, has nowhere to escape, and it keeps building, and causes pressure on all of these tissues here. Compartment syndrome can also occur in the abdomen and in a brain injury. Mostly what you're going to see within, when we refer to compartment syndrome, is with these limbs. When the tissue swelling reaches a critical point, the circulation to the area is blocked, and oxygen is deprived from those tissues, so it can actually kill those tissues. So, in order to save somebody's leg, an acute compartment syndrome requires emergency surgery to relieve the pressure. So you can see here, and there's also a video on a fasciotomy that's done where all they're doing is making large incisions into the fascia, so it can release that pressure and allow the tissue to become oxygenated once again. The Advanced Trauma Life Support Principles, the ATLS principles of trauma management, is based on very specific objectives. These objectives are: the most life-threatening issue is treated first. So you can have somebody come in with multiple problems. We're going to pick the biggest fire to put out, the thing that is going to, causing most threat to the person's life. Second would be treatment is initiated even when a diagnosis has not been established. If you really think about it, this is very unusual. Usually we have a specific diagnosis before we start treatment. With trauma, you need to move fast. So there's decisions that are made quickly, and sometimes you can't have a true diagnosis before actually beginning treatment. And third, treatment may be initiated even when there is no detailed history. ATLS trauma assessment is performed in 2 stages. First is the primary survey or field care performed by first responders. This would be your EMTs or firemen, police officers. This is anybody that's on that scene first. They use the ABCDE sequence. This is airway, breathing, circulation, dysfunction, which means the patient is checked for traumatic brain injury, and exposure, which is the full scale of the patient's injury being assessed. Resuscitation begins immediately in the early assessment stages of trauma and continues as long as necessary. It is the process of restoring physiological balance in injury. It treats hemorrhagic shock by establishing normal circulating blood volume, tissue perfusion, and vascular tone. This is done through careful monitoring. Um, so it would be done through IVs, it's done through CPR. The goal is to achieve and maintain normothermia with sufficient oxygen carrying capacity, with adequate coagulation factors and adequate fluid pressure that does not increase hemorrhage, which means that if we dump a bunch of fluid into a bleeding patient, it's going to raise the blood pressure, yes, but then we're also going to increase hemorrhage. So it's a balance, a physiologic balance, making sure that we keep the patient at a high enough blood pressure that's going to sustain life, but low enough that we're not going to increase bleeding. The secondary survey is performed once the patient is stable enough to be moved to the hospital. So the patient may be transported directly to will be transferred to the ER and possibly directly to the OR after primary assessment. A head-to-toe examination is done to look for less obvious injuries that also may be critical. A verbal history is obtained from the patient or from witnesses who can provide any details of the trauma. Consent is also required for invasive procedures. These can be obtained from the patient themselves, if coherent, or from responsible individuals, according to hospital policy. Documentation of all care is essential. Forensic medicine is the study of interpersonal violence. So if we have a gunshot wound, if we have a battery, that's interpersonal violence. This is violence from one human being to another. This can be considered criminal. Forensic medicine is going to keep track of all of that evidence, to make sure to see if we can come to a conclusion about the interpersonal violence. If you're working in a congested urban area, odds are you're going to have some experience dealing with evidence. Death from firearms is the second leading cause of mortality in the US. Approximately 115,000 cases are treated each year. The surge tech should handle evidence as he or she would handle any specimen. We're going to use extreme caution and being sure that we keep all specimens, keep good track of all specimens. When dealing with the removal of bullets or fragments, you want to try to use a rubber coated or a sponge coated instrument when removing these bullets. So this actually is not the greatest picture of this, using metal on metal. We want to avoid it as much as possible. Bullets will have markings on them that we don't want to add to the markings that can confuse identification. Damage control surgery is a specific surgical strategy whose exact technique depends on the body systems involved and the likelihood of improving prognosis. The goal is to focus solely on life-saving maneuvers. So those life-saving maneuvers: control of hemorrhage and fecal spillage, pack a body cavity, delay the wound closure, relief of compartment syndrome, or splinting or external fixation. If the patient is stabilized in 12 to 48 hours, they can be returned to surgery for a definitive procedure that would use a planned method and techniques that are intended to provide a lasting repair. In case planning for trauma cases, all surgical departments should have emergency case carts prepared for specific emergencies. They should be in a specific hallway. Everybody should know where to find them. You'll see like an emergency craniotomy or an emergency general case. When planning for a trauma, you want to start with basic instrumentation. Avoid opening tons and tons of trays. It's an easy thing to do because you're unsure of what you need, but we don't want to get overwhelmed with an amount of instrumentation that we're actually not going to use. So bring those instruments nearby, leave them unopened on a case cart right outside the room. So that they're easily accessible, but that we don't have them opened on our back table. Copious amounts of irrigation solution are going to be needed during trauma surgery. It's used to flush and clean the wound. You remember, often these wounds are dirty. They were caused by dirty objects. So we want to make sure that we're irrigating, lots and lots of irrigation. You always want to have suture on hand. It's a good idea to start with some basic suture, 2 and 3/0 silk ties, maybe a Vicryl tie, throw in there too, along with a 2 and 3/0 Vicryl stick tie. You want to just have something on hand that can be used in an emergency. Thrombin-based tissue sealants are only used if coagulopathy is not present. You have to have an intact coagulation response for thrombin to work. So there's no purpose in opening it unless that patient is not in coagulopathy. The physiological changes brought about by trauma can cause severe edema. Which means we're going to have a lot of we could have a lot of post-operative serosanguinous pooling. Serosanguinous is thin, watery, pale red fluid. It has some blood, it has some serum. We want to make sure that we control this with the appropriate wound drains and dressings. During preoperative care, when we're moving and handling the patient, a couple things to think of. Positioning the trauma patient requires precise coordination among every member of the surgical team. There's a real potential for extending a patient's injury during moving and handling. If somebody has a neck injury and we're not moving carefully, we could literally cause paralyzation of that patient. All movements are directed by the surgeon or anesthesia, and get into the habit, and this is even outside of trauma surgery. You don't move unless you hear that 1, 2, 3 by the anesthesiologist or the surgeon. Maintaining patient normothermia is extremely important, as important as when we're discussing it for the pediatric patient. So it's a real good idea to think of all those things that you do during peds. This is what you're going to do during trauma as well. Keep the room warm, maintain the patient's core temperature through use of bear hugger, warm irrigation. All those same types of things should be done for the trauma patient. Emotional support. Trauma patients will often be disoriented and frightened, and powerful emotional reactions to the trauma can really affect the body's physiological mechanisms. So those same chemicals that induce and prolong metabolic shock are activated by this emotional trauma. We really want to keep this in mind. All activity is absolutely focused on life-saving measures. There's no question. However, it is possible, someone should offer some level of emotional comfort to that patient. Opening a case, in emergency circumstances, some of the usual routines are abbreviated. You may be donning a gown and gloves at the same time that your surgeon is. You just do not have the same amount of time as you do in a typical day. During trauma surgery, the American College of Surgeons, as well as AORN, have stated that standardized counting procedures may be suspended in a life-threatening situation, meaning that if we do not have time to count those instruments, then we will just do an x-ray at the end. We are allowed to bypass the count at that point because we're in this mode of just trying to save this patient. Try not to overload the back table. Again, don't open everything. And one of the best tips is to prepare the mayo in the order of its immediate use. Really spend some time, as much time as you can, thinking about start to end of case. What are we going to need? That surgeon needs gown, gloves, and drapes before you can even touch a knife. So that should be the first thing you're getting set. Your bovine suction should be the second thing, and then the knife. Think of the order of how it's going to go, and don't start working on suture without having your gown, gloves, and drapes ready to roll. Lastly here, sterile field management and trauma. Managing the sterile field during a trauma requires a high level of attention to the wound. Remember, trauma surgery is performed in order of priority, not necessarily what we're used to seeing. So, however much case studying you've done or how many cases you've done, when you're in trauma, it kind of, it goes to exactly what's going on with this specific patient. So, you need to pay close attention to the procedure. Stay with the surgeon. Even when you're doing other things, you really want that focus to be on what the surgeon is doing, trying to anticipate the surgeon needs, and really, really attentive to the procedure itself.